Thanks, Vineet, for the introduction. And I would like to thank Somshila for inviting me for the session. I'll just share my screen. Yeah, is the screen visible?
Yes, sir.
Doctor. So basically, we'll be going through a brief overview of keratoprosthesis as what we have at this point of time. No financial disclosures here. So I'll be going through the different types of keratoprosthesis, the indications, the preoperative issues, assessment, and the techniques, and just show some of our results with challenging cases. So when you're talking of keratoprosthesis, the primary indication is a patient who has bilateral corneal blindness. By and large, most keratoprosthesis surgeons do not advocate keratoprosthesis when there is some vision in the other eye. And if you look at literature, most of the cases that have had keratoprosthesis are primarily those which were due to multiple failed grafts. If you look at Stevens-Johnson's OCP and chemical injury, they form a smaller subset, but these are the most challenging cases where we actually need to perform keratoprosthesis. So if you look at type of keratoprosthesis, you have it as either a biocompatible, where you have the Boston type 1, the biointegrated, the Pin2G. Unfortunately, it's not freely available these days. And you have the biological keratoprosthesis, where you have either the osteodontal keratoprosthesis or the tibial keratoprosthesis. When you're talking of Boston type 1 keratoprosthesis, the indication basically is in a moist eye where there is good blink, there is no exposure of the ocular surface, and preferably in a non-immunological condition. When I say a non-immunological condition, I basically mean SJS and OCP, because in these cases, you would probably prefer a type 2 keratoprosthesis. Also, some of the severe chemical injuries where there's significant lid globe anomalies, you would probably want to do a type 2 keratoprosthesis rather than a type 1 keratoprosthesis. Coming to the choice of keratoprosthesis, when it's a keratinized ocular surface or with severe lid globe anomalies, you would probably look at MOOKP being the keratoprosthesis of choice. However, in a patient who's edentalist or with poor oral hygiene, you might look at the tibial keratoprosthesis, or you might look at the Boston type 2 keratoprosthesis, especially if the patient cannot have multiple general anesthesia procedures during because of his age or systemic condition. Pediatric keratoprosthesis at this point of time is not routinely recommended. So when you're looking at preoperative assessment, obviously the potential of vision has to be noted. The ocular status with respect to the lens status, the axial length has to be noted. The IOP has to be measured. If it is not possible with any instrument, a finger tension probably would be the way to go. You have the option of looking at the angled chambers with the help of a UBM, or looking at the posterior segment with the help of the endoscope. And you need to be sure that the patient has systemic fitness for general anesthesia. Psychological counseling plays a very important role, and lifelong follow-up cosmesis, and the patient should have realistic expectation. Coming to the Boston type 1 keratoprosthesis, you also have the orokeratoprosthesis, which is made in India by Orolab. So this video basically shows the assembly of the keratoprosthesis, and it's a fairly simple assembly where you place the optic at the center on a sticky tape so that it doesn't move. Keep the punched cornea on it, and then you put a back plate, and then the entire assembly is secured with a titanium locking ring. At this point of time, you also now have a click-on or a snap-on back plate, and you have the back plate which is being changed from the PMMA to the titanium because it is more better biocompatible. In a type 1, you basically need lifelong prophylactic antibiotics. You would probably need a contact lens to keep the cornea hydrated. You also have the option of newer tissues for the optic in the form of a cross-linked donor cornea, which are being tried. The post-operative care basically is in the form of topical steroid, which is tapered and continued at twice a day or once a day endlessly. And you also have topical antibiotics in the form of 4th generation fluoroquinolones and a vancomycin or a chloramphenicol, which is continued twice a day lifelong because the patients are on contact lenses. We do advocate povidone washes, that is betadine, once a day, once a week. And we normally give voriconazole drops for a couple of days every 2 months. This was one of our first patients where we did keratoprosthesis, the Boston type 1, for a silicon-induced keratopathy. And she's maintained 20/60 vision for about a 13-year follow-up. And this is what we published in 2011. This is another patient who developed a bilateral chemical injury, had a bilateral PK, and then he underwent a Boston Kpro and is maintaining 20/100 vision. A patient with a failed graft maintaining 20/80 vision. One of our pediatric patients who has some amount of ambulatory vision, which is a pediatric sclerocornea, who had multiple failed grafts. All keratoprostheses are prone to complications, so you might have to look at epithelial defects, and if it is not managed properly, would lead to melts, which requires anacrylate glue and fistula formation or an LK. And the most dreaded complication would be endophthalmitis that you would want to be aware of. When you have corneal melts, you might want to do a lamellar graft. You can do a partial lamellar graft where you are doing it like a crescentic lamellar graft, or you might want to complete the 360-degree graft where you have to snip the tissue in between and hug the graft around the optic. So our results, we've done about 65 patients where we've had about 80% anatomical success and about 70% functional success. A type 2 is similar to a type 1, except that you need to have a skin closure to it at the end, and there is a protrusion through which the optic projects out. So our results with about 10 patients, we have had about a success of about 90% in anatomical, and functional success is about 7%. And these are some of our patients who have maintained useful vision in their only eye over a period of 7 years, 4 years, and 5 years follow-up. When you're looking at OOKP, basically it is done in 3 stages. The first stage is the preparation of the eye, where we remove the iris, remove the lens, and do a PK if required. The next stage, we take the canine teeth, split it into half, drill a hole in it, place an optic cylinder there, and then take a buccal mucous membrane graft and drape the ocular surface. And this is then placed in a cheek and allowed to vascularize. And then finally, the third stage, we place it on the eye and it is covered by the buccal mucous membrane graft. So the maximum literature report has been by the Falcinelli group, where they have reported a success rate of more than 80%. Our report with about 100 patients that we have done, we have an anatomical success of 68% and a functional success of 66%. OOKP also has its own complications. You could have peripheral mucosal melts with protrusion of the bone, which needs to be managed either with a pedicle flap, or if it's more of a central melt, you would need through the lid keratoprosthesis. Laminar resorption is an issue, and we've published our report on how laminar resorption could be managed and the lamina could be salvaged at least for a reasonable period of time. It does have problems of endophthalmitis and RD, but they are also mostly seen in patients where there is laminar resorption. If the lamina is functioning well, generally a glaucoma or RPM is very, very unlikely in OOKP. You have the type 2 modifications, where basically they were started off as a desperate measure when the lamina gets resorbed and to give vision for these patients. And I would like to thank Professor James Shorosh for giving us the option of using the Lucia Type 2. It's no longer available, but you could still use the Boston Type 2 under the mucosa in these patients. And the last option would be something called as the Temprano or the tibial keratoprosthesis, where if you don't have a good tooth, but you have a good bone, you could probably use the tibial bone as a carrier or for your optic. And this is done similar to the OOKP in the same stages, except that you're using the bone instead of the tooth. And this is our patient who regained about 636 vision in his only eye. So to conclude, recent modifications have expanded our indications. They have given us better results, have improved outcomes of keratoprosthesis. However, patient selection, counseling, and regular follow-up plays a very important role in maintaining the gains that we have had in these desperate cases.